Welcome, everyone. We're so glad you've joined us for today's webinar, Community Health Worker, Promotor, and Community Health Representative Solutions for Enhanced Care Management. My name is Chrissy McKenzie, and I'm the Director of Strategic Initiatives at Health Leads, and I will be serving as today's moderator. Before we get started, we just have a couple quick tech instructions. If you would like to listen to this webinar in Spanish, please click on the globe icon at the bottom of your Zoom screen and select your language. Everyone, including English speakers, must select a language to ensure a smooth interpretation experience. You can also turn on closed captions by clicking the CC icon and choosing Show Subtitles. Si desea escuchar este webinar en español, haga clic en el icono de globo en la parte inferior de su pantalla de Zoom y seleccione su idioma. Todos, incluidos los hablantes de inglés, deben seleccionar un idioma para garantizar una experiencia de interpretación fluida. También puedes activar los subtítulos cerrados haciendo clic en el icono CC y seleccionando Mostrar subtítulos. The speakers, including myself, will do our best to speak clearly and at a steady pace to help create a quality audio experience for the attendees listening to the webinar in the Spanish channel. Before we begin, I want to take a moment to ground us in a land acknowledgement. I'm joining you today from St. Paul, Minnesota, which is the native land of the Dakota people. I honor their enduring connection to this land in the past and the present, and recognize the strength, resilience, and contributions of Indigenous communities across the country. In the chat, we invite you to introduce yourself, where you're joining from, and name the Indigenous nation whose land you're on. You're welcome to share how you acknowledge or take action to honor that land and those people. We've dropped a couple links in the chat to help you identify the land you're on if you're unsure. Welcome again to the Community Health Worker, Promotor, and Community Health Representative Solutions for Enhanced Care Management. Today's webinar is part of the Amplifying Impact Initiative. Through this initiative, we're highlighting local successes, sharing workforce tools, and offering high-impact technical assistance to help organizations grow and sustain their CHWPR integrated Medi-Cal program efforts. This work is made possible by the California Healthcare Foundation with additional support from Cedars-Sinai. If you're interested in learning more about the initiative, a link to the landing page will be available in the chat. I'm now pleased to pass it to Carlina Hansen, Senior Program Officer at the California Healthcare Foundation.
Greetings, everyone. Thank you so much for joining us today. It brings me great joy to be in community with all of you as you advance your work with community health workers, promotores, and community health representatives in service of the health and well-being of people in California. Just to tell you a little bit about us, the California Healthcare Foundation is an independent nonprofit philanthropy that works to improve the healthcare system so that all Californians can have the care that they need. We focus especially on making sure that the system works for Californians with low incomes and for communities that have traditionally faced the greatest barriers to care. I also want to appreciate our wonderful co-funders in Los Angeles, Cedars-Sinai, and our program officer, Teshma Nash. Community health workers, promotores, and representatives are uniquely positioned to bridge the divides between the healthcare system and diverse communities to achieve health equity. They perform a variety of roles, as I think many of you know, from supporting care transitions and referrals to encouraging and educating patients on how to take care of their own health. Their work is incredibly important at any time, but all the more so when people are facing threats to their health and well-being. Things like COVID, wildfires, or fears related to immigration status can impact people's health and do impact people's health and create barriers to accessing services. Community health workers, promotores, and representatives are on the front lines as we speak, helping people find their way through these challenging times. And for that, they deserve our endless appreciation. CHCF just released a new report about the role of community-connected workforces in CalAIM, which is based on a statewide survey of people implementing CalAIM. We're going to put that in the chat for your reference, and I hope that it'll help you as you seek to understand their role in the Medi-Cal system. I want to give a big thanks to our panelists for joining us today, who are going to share more about their important work. Huge gratitude and big thanks to the team at Health Leads for organizing us today. With that, I will turn it back to Master of Ceremonies, Kusi McKenzie.
Thank you, Carlina. All right, here's what we'll cover today. I'll do a quick overview of enhanced care management, and then our panelists will do self-introductions, followed by a rich discussion where panelists will share real-world models, financing strategies, and lessons learned. Enhanced Care Management, or ECM, is a Medi-Cal program that provides whole-person, high-touch care coordination for individuals with complex needs. ECM aims to improve health, reduce unnecessary hospital visits, and provide a stronger support network. It brings together physical health, behavioral health, and social services delivered in homes, clinics, shelters, or wherever is most convenient for that person to receive care. We have dropped a link to the ECM webpage where you can access the fact sheet and get more detailed information about populations of focus and becoming an enhanced care management provider. So who delivers ECM? At the heart of the care team are community health workers, promotores, and community health representatives, trusted members of the community who build relationships and bridge gaps. They work alongside nurses, social workers, and behavioral health providers to deliver care that is holistic, person-centered, and grounded in lived experience. Today's panelists bring enhanced care management to life in a powerful ways. We're joined by Renee Santos and Ellen McGinnis, both of whom began as community health workers and now serve as lead care managers, bringing lived experience directly into care coordination. We'll also hear from Felipe Flores, Director of Community Health Workers and Promotores at San Francisco Community Clinic Consortium, and Janice Briones Landeros, Clinical Operations Director at United American Indian Involvement. This is a unique opportunity to hear from both frontline care team members and program leaders, offering a full picture of what it takes to deliver ECM through a CHWPR lens. And now I will pass it to Janice to introduce herself.
Hello, everyone. Good morning, and thank you for the introduction, Ms. Kusi. I am very pleased to be part of this wonderful group and to impart some of our best practices in United American Indian involvement. Again, my name is Janice Briones Landeros, and I am the current healthcare clinical operations for United American Indian Involvement. I've been with UAII for maybe roughly over just 14 months. My background is I have been in healthcare for the past 21 years as a registered nurse. My passion in the nursing arena, the nursing realm, is really teaching, education, development, operation, patient care, and definitely advocating for our underserved and most vulnerable population in the community. It's again like an honor for me to be part of this wonderful like panelists, and I'm here to also learn from everyone here this morning. So yes, and let me pass on the floor to Felipe.
Hi, everyone. Good morning. Buenos dias. My name is Felipe Flores. I use he, they, ella pronouns. I'm joining you from unceded Ohlone territory, commonly known as San Francisco. I am born and raised in San Francisco of Mexican and Salvadoran descent. I have over a decade of healthcare experience where my focus initially was more in the HIV and sexual health field, but my primary focus in all of my work has always been mobilizing and engaging our communities to access healthcare services. I currently serve as the Director of Community Health Workers and Promotoras at San Francisco Community Clinic Consortium, where I lead a workforce development program focusing on community health workers and promotoras, working with 8 of our community clinics to build and integrate CHWs into our work. I'm excited to kind of share a lot of what our different clinics are up to later on, but I'm happy to pass on to Ellen.
Hi, good morning, everyone. Thank you so much for all being here today. My name is Ellen McInnes. I grew up in a very small town in rural New York, which had less than 1,000 permanent residents. I would say that this was an integral experience for me in learning community building. From there, I moved on. I completed my bachelor's degree in 2022 at Dickinson College in Carlisle, Pennsylvania. And from there, I moved to the Bay Area. 2022 was the same year that I began working at Native American Health Center. In terms of my journey towards community health work, throughout my undergraduate career, I knew that healthcare was always a goal for me. However, I wasn't exactly sure which part of healthcare would be right for me. I am Indigenous born from Ecuador, and I had integrated this into my studies. I completed a thesis project that was a case study focusing on an Ecuadorian midwifery group and their strategic manipulation of social media platforms to stimulate community action, as well as also integrating traditional healing practices. Their work revolved around staying with their patients for the entire health journey. And this experience and that research really highlighted my desire to be on the side of healthcare, in which I had had the ability to interact at a deep level with the populations that I served, spending hours at a time if necessary, and also connecting with Indigenous communities. I was really lucky and found this opportunity to do so at the Native American Health Center through the Community Health Worker Program with support from the San Francisco Community Clinic Consortium, and now the Enhanced Care Management Program. I'm really excited to speak more about this, and I'll pass it off to Renee.
Good morning, everyone. My name is Renee Santos. I go by he, him pronouns. I am born and raised in San Francisco, so it's a pleasure to be able to serve the community I grew up in. Our Native American Health Center is located in the Mission District, so right in the heart, right on 16th and Mission. I grew up walking these streets. I grew up around this neighborhood, so it's a blessing to be able to help the people that I've been around my whole life. I did my undergrad at San Francisco State. I did sociology with a minor in political science. While I was doing my undergrad, I was able to complete a 6-month internship at La Raza Centro Legal, where I was able to learn a little more about the immigration systems, the lingo that they have, and all the documentation. This has served a lot when I've tried to help members through their immigration journey. A lot of the lived experiences I have walking these streets and being in this community has really helped me. And I will now pass it on to Felipe and Janice.
All right. So we're going to kick this off with a couple questions. So first, I'm gonna pose the same question to both of you, and I'll start with you, Janice. So tell us about your organization and your enhanced care management program, and what the financing model looks like for your program.
Yes. So United American Indian involvement, just like a brief history and how we were founded. So we were founded by 2 powerful Indigenous women in 1974 as a response to the Relocation Act, as a response to the Indigenous Relocation Act in 1956, displacing, I think, more than like 100,000 of our AIN and AN of community. UAII, we are located in the heart of Los Angeles, which is in Echo Park. I don't know if you guys are familiar with the area. Felipe's nodding, so you're probably familiar with the area that we're serving, the community that we're serving. So, so our focus and our main focus for United American Indian involvement is dedicating to meet the needs of our American Indian and Alaska Native communities, but through recent years, our doors are not just open to our AI and our AN communities, but also open to the underserved population and the most vulnerable. So practically whoever needs help, either you're uninsured, you have medical insurance, or whatever shape or form you are actually welcome in the doors of UAII. Our services include medical, dental, behavioral, youth programs, housing assistance, and community wellness initiatives. The heart of UAI's mission is a commitment to healing through culturally grounded, family focused, and trauma informed lens. So we consider ourselves as an urban Indian organization. We look at our model as a one-stop shop. Again, having the healthcare, like the dental, behavioral health, substance abuse, but not only just imparting healthcare side, but also focusing on social determinants of our community. So treating our patients holistically, integrating integrating the resources that we have internally. So it's basically like interdisciplinary approach that we provide care to our community. So our ECM program, our Enhanced Care Management Program, is an extension of the mission of UAII. So we serve high need, high risk medical enrollees who faces complex, not just medical, but behavioral and social barriers to health. So many of our ECM clients are navigating multiple systems while experiencing housing instability, chronic illness, and mental challenges, or re-entry or incarceration. So currently right now for UAII, the model of our ECM program is I have one ECM person. Her name is, I'm just gonna, make a shout out, Nancy. Her name is Nancy. So she is our ECM coordinator. And with her, I have other 4 CHWs that is being led and managed by my wonderful supervisor, Miss Shendine. Also a shout out to Miss Shendine. And then the way that we are funded and the way that we sustain our ECM model, and I'm just going to be as transparent as I can be. We do face a little bit of challenge in terms of financing our ECM programs, stable and equitable funding models. That's what we're trying to seek right now. So we are contracted with IPAs, with medical IPAs such as LA Care, HealthNet, Molina Healthcare, and through the CalAIM program, through the CalAIM initiative, which I think most of us are quite familiar of the CalAIM initiative right now. So that's the main source of our funding. But we do think that that is not sort of enough to sustain our ECM program. So what we're trying to do right now is be creative as we can, such as braided funding models. So the braided funding models is basically integrating federal, state, and philanthropic or non-for-profit organizations. So we're out there doing outreach, talking to people, talking to non-for-profit organization and telling them that, hey, we're here. We can actually service our community. So we're there, buying in for grants. And I do see that in the chat that if we are applying for the round 4 path cited, and the answer is absolutely yes. We actually, I think, just like almost like completed our round 4 path cited application, and hopefully that we will be granted for the round 4 as well. But again, that is sort of like the model of our funding source right now, is not just solely heavily relying on the CalAIM initiative or the path cited, but also having to develop braided funding, going out there looking for grants, CDC grants. There's actually really a lot of grants out there that do want the model of like the ECM program, because the ECM program is, you know, our CHWs, they are our community people. They have already built rapport and relationship to our folks. So building rapport and relationship and trust in our community to buy into the ECM program and the CHW program is actually very integral in having a successful and robust ECM program. So yes, thank you.
Thank you, Janice. And then Felipe, same question. Tell us about your organization, your enhanced care management program. I know it's a community clinic consortium, and then financing models that you've seen across maybe some of your clinics.
For sure. So I'm a storyteller, so bear with me. I'm going to go through a little bit of the consortium history, our CHW program, and then kind of end on our ECM program. So San Francisco Community Clinic Consortium, we are a membership-based organization where we represent 12 different community clinics here in San Francisco. We are the largest set of safety net clinics here in San Francisco, serving over 100,000 Medi-Cal members every year. Each of our clinics is pretty distinct in terms of the communities that they prioritize and center. Of course, today we're spotlighting the Native American Health Center. We also have the Mission Neighborhood Health Center that centers more the Latin and undocumented community. We have different community clinics that focus on queer and trans communities, the aging population, unhoused folks, substance users, kind of a wide variety of different communities that our clinics serve. In terms of the work that the consortium does, we do a few different things. So one is funding and grant management support. So we support our clinics in kind of what Janice was sharing, like looking for all of those different funding and grant opportunities. So we manage Healthcare for the Homeless grant, a huge federal grant for our clinics. We also have Ryan White funding, and we also have like philanthropic organizations funding programs such as mine, our CHW program. Another area of work that the consortium does is workforce development. So we have an AmeriCorps program, we have an AHEC Scholars program, and of course the CHW program that I'll highlight in a second. And then lastly, we also offer some direct services. So we have our street outreach services program, which works with unhoused folks, meeting them where they're at. We have a mobile van that travels through different neighborhoods in SF, really kind of meeting people where they're at. And we also have a veterinary street outreach services program, which works with the pets of unhoused folks and works to support the pets of folks and connect the owners to healthcare services as kind of an innovative approach to connecting with unhoused folks. So in terms of our CHW program, we started 3 years ago in 2022. It is a workforce development program where we're a local private foundation here in San Francisco provided the consortium funds to hire and train new frontline workers, specifically community health workers. It was a very generous grant earlier into the pandemic where we were able to fully fund CHW positions at clinics. So most clinics were able to hire 1 to 3 CHWs that were fully funded through this grant. So we weren't really worried about billing at the time. It was really, how can we integrate CHWs into our community clinics where they will have the most impact? For each clinic, it looked a little bit different since CHWs, we know, can provide a wide range of different roles and responsibilities. Some clinics focus more on outreach efforts, right? Like door to door at low income apartment buildings here in the neighborhood, or calling folks, doing different like outreach events, tabling, going to schools, whatever kind of the focus for that community and clinic was, CHWs, would be doing outreach efforts. Some clinics focus on building more social support programs. So whether that was like art and drawing, whether that was drumming, dancing, whatever that looked like for that community, finding different ways to break down isolation and help bring our communities together. And then the last kind of big bucket area that a lot of clinics built out was kind of what we call like ECM light, where they're doing all the work that an ECM or a lead care manager would be doing, but we weren't really billing for it at the time. So while we were building our CHW program, the conversation around CalAIM and ECM was kind of building up more and more. In San Francisco, we have 2 kind of managed Medi-Cal plans, San Francisco Health Plan and Anthem Blue Cross. where San Francisco Health Plan has about 80% of Medi-Cal members in San Francisco. So they're definitely the largest plan here in San Francisco. And after seeing the success of the CHW program and having a person dedicated to that work like myself, really leading the charge and keeping up to date with all of the policy changes that were happening at the time around state certification and the Medi-Cal benefit, our leadership team at the consortium worked with San Francisco Health Plan to create and fund a role very similar to mine that was focusing on ECM efforts. So one of my colleagues, Paul Quinn, he is what I do for CHWs, but for ECM. So he's really focused on keeping the policies, sending out the funding opportunities, all of the kind of details of this really complicated program that is ever changing, right? It's always growing. There's new things being added, different things, different counties look slightly different. So having someone dedicated has been really helpful. He leads a collaborative group here that meets monthly for all different ECM providers in San Francisco. And that's been a great space for skill sharing, peer support, technical assistance, seeing like, oh, were you able to do this? How did you do that, right? All of those kind of like technical things. Similar to what Janice was sharing, a lot of our clinics' financing models are graded, where some of the clinics that I work with, Paul and I, our programs overlap in 4 out of 8 of the clinics, where 4 clinics who have CHWs have fully integrated their CHWs into either being lead care managers under ECM or being part of an ECM team. So in terms of funding, we have funds that come directly from my program. We're not able to fully fund positions anymore. So we're funding maybe like 40% of someone's work. And then they're supplementing that through billing with ECM. And also some of our clinics have had TAP-cited funding, like was mentioned. Some of them have also been able to access IPP funding, so the incentive payment program, to kind of supplement and ramp up their services. Each clinic is kind of unique in terms of where they are able to also bring in additional funds within their organization. But overall, I would say it's a graded funding model now, but is looking to and moving towards ECM as hopefully being the sustainable model moving forward. I think that was it. I think that is kind of my overview of some of our work and programs.
Thank you both so much. So it sounds like it's complicated and it's a work, and definitely we're still at a stage where braided funding is really necessary to sustain these enhanced care management programs. Well, thank you so much. We'll see you back in a second, in just a little bit. I'm going to ask Renee and Ellen to come on camera. All right. So we'll start with you, Ellen. What does your typical day look like as a lead care manager? And what is unique about your role that supports your clients and your care team?
I would say that our days can vary a great deal. Some days we are solely in the clinic at our desks doing documentation. Other days we're off site all day. The schedule that we have really revolves around our members' schedule, and I would say that flexibility is the key here, being able to have time and designate it where it needs to go. We go anywhere that our patients go. This includes social service offices, housing navigation centers, shelters, their homes, and their respective clinics if they are not patients at our own Native American Health Center clinic. We also have a fair amount of drop-ins. So for some folks, we see them 3 to 4 times a week. And we have also established a warm handoff desk for this purpose that we all rotate, the team does, to address any of those walk-ins, those concerns. We kind of have a no wrong door policy in which we're able to connect our members any which way they need to go, as long as they come in and just ask their questions. We also work very closely with all the departments in our clinics, especially the community wellness department. A lot of our members go there to connect with the cultural programming and whatnot, and that programming is every day. And so if we have time, we also go to sit in community with our elders for beating group, for maker circle. That's where we really kind of continue those relationships that we make. We have a lot of really great resources as well, and I would say that we constantly exist in multiple spaces. We're dancing on the line between clinical and non-clinical, and the relationships I make are really, really important for this, especially my team internally. All 4 departments that we have on site, I would not be able to be successful in my work without that support. And externally, I also really kind of focus on the resources that I've been able to bring patients through successfully. And, you know, that would include housing, transportation services, in-home support service, social workers. It's really great to be able to call them up, call them by name, have a conversation, and really kind of have that group think going on. And I think that these relationships are not only for myself, but while I'm maintaining those, fostering those, I'm also doing that and building a network for my patients. As an extension of this, I think that making ourselves visible outside of the 4 walls of an exam room is really important. That's what builds trust. And so overall, I think those are really, really integral aspects of what our positions look like.
Right. And as a follow-up to that, what's the best resource that's been the most helpful to you in serving enhanced care management clients, and why?
Honestly, I would say the community that we've built through the consortium. You heard Felipe kind of talk about Paul's group as well. I think those groups are really integral to kind of, you know, talk about issues, talk about what problems we are all facing, how we can overcome those, and really kind of building that kinship and familial connection with other groups around. A lot of times our patients aren't necessarily going to have their primary care at our clinic. And so having those connections, like I had mentioned with Mission Neighborhood Health Center, for example, really just strengthens our ability to navigate the internal and external healthcare systems for our patients. And this is also kind of going towards like the administrative side and being able to kind of have someone to voice possible recommendations and, you know, what we think would really be beneficial to our members and how we're kind of navigating the ECM process while also making sure that quality of service is maintained to the highest extent. So I think it's been really nice to have those connections from community health worker to now lead care manager into the ECM program, and really grateful for that.
Awesome. Thank you, Ellen. So I'm going to pose the same questions to you, Renee. What does your typical day look like as a lead care manager, and what's unique about your role that supports your clients and care team?
Yeah, of course. Ellen kind of highlighted a lot of the things that we do in our typical day, going out into the community with members. That's one of the things that I really enjoyed about this work, and that I had opportunity to not just stay in the clinic. I always tell people that 50% of the job is out in the community, being with members at their appointments. The other 50% is really just in the office, drop-ins, catching up on charts, things like that. I also think that it's really nice to be able to do that transition, because as CHWs, we were limited at the things we could do. We really couldn't do home visits, but transitioning into ECM, that's one of the things I enjoyed doing, going to people's homes, just because some people couldn't leave their homes for X amount of reasons, and being able to meet them at their home or at a local park, just somewhere where they feel comfortable, and then slowly bringing them back into the clinic. We also, Ellen and I, we were the first CHWs at our clinic. So a lot of the times we were just doing a lot of research, just trying to figure out where we can go, a lot of the city resources. So I think that a typical day there is no typical day really. Every day is really different. We tend to see a lot of our medical patients. The beauty of it is that we're at this site in San Francisco. We're somewhat a little small, but I love it just because a member can come in for their medical appointment and then also see a clinician that same day and then also see us. So a lot of the times we go with members either to their dental appointments here as well. We sit with them. Sometimes they just need that type of support. So really just whatever the member needs, like Ellen said, we're there for them. We try to be more of a friend than anything. You know, medical providers can be a little scary. Going to the dentist can be scary. Seeing your clinician, you know, can be scary, but they always come in and they always say, "I'm happy to see you," which is the best part of my day.
That's awesome. And what would you say the best resource that helps you the most as a lead care manager?
I would say, like I was saying a little earlier, the first few months of me and Ellen working here, we were just going out into the community and we created this sort of resource binder, which
Mhm.
is really ideal just because if a member comes in and they say, "Hey, I need help with this thing," we just go to our binder. So a lot of that took just going out to human services agency offices, seeing how to apply for Medi-Cal, what the process looks like, going to the disability and aging services, seeing how we can get people IHSS and other veteran services. I would also say every morning the medical team has these rounds. So us care coordinators, we go every morning, we go through the list of members that are coming in that day. And like I said, some of our members are our ECM members and our medical members. So that's the chance where we get to update the medical team on what's going on in their life, not just medically, but also emotionally. Um, and I would say a big thing was our learning community that we had through Felipe and the San Francisco Community Clinic Consortium. We were really able to build those relationships with other CHWs that are also now transitioned into ECM. Um, we would do a lot of trainings. Some clinics offered things that we didn't hear. Some clinics had podiatry services that if you know, at San Francisco General, it's really hard to get people into that clinic. So we can refer them to, for example, St. Anthony's, and that's sort of like a walk-in thing. So members can get that service a little quicker. Other clinics also have optometrists, which we don't have here at the health center, but it's really hard to get them also at San Francisco General. So being able to call a CHW or an ECM member saying, "Hey, can you help this member get enrolled in services in your clinic?" So those relationships really benefited us. And I think lastly, what we try to do here at the Native American Health Center is all this, all of us care coordinators sit in the same space. So we see each other's members all the time. We try to introduce ourselves to each one of our members in the case that one of us isn't here for X reason. We might be out sick or something, but they can come in and say, "Hey, you're not a stranger. I've met you before. You know part of what I'm going through. Can you help me?" So that's a real beautiful thing that we have here.
Thank you so much. So it sounds like relationships seems to be a central piece, whether it's relationships with your community or relationships with other clinics. So that's lovely to hear. I want to bring back all the panelists so we have the audience has had a lot of questions. And so we're going to try to get to as many as we can. And if we're not able to get to all the questions, we'll try to get back to those folks via email. All right, so we'll kick it off. So this one may be for maybe Janice and Felipe. How do you avoid double billing when community health workers are providing services under the community health worker benefit and enhanced care management program?
I can get us started. Um, so the majority of our clinics are FQHCs or lookalike, and as Renee was sharing, a lot of our clinics with our CHW programs, this was like the first time or the first time in a long time that they've had community health workers as part of their team. So the CHW benefit wasn't added to the clinic's PPS rate. It's a little technical, into their PPS rate. So given that the reimbursable rate is so small with the CHW Medi-Cal benefit, most of our clinics just kind of decided not to move forward with it. It is, I think in the state of California, the CHW Medi-Cal benefit just hasn't been utilized that much for this reason, where it's really complicated for FQHCs particularly to engage and kind of integrate that into their services. So a lot of folks will provide the services, but just not bill for it. So of our ECM programs, none of them are doing the CHW Medi-Cal benefit. We do have one of our clinics, Planned Parenthood, who is piloting the CHW Medi-Cal benefit, but they're also not an FQHC, right? So they're paid through a different mechanism. If that was the situation where we could offer both, the CHW Medi-Cal benefit is more open in terms of eligibility of what a patient or a Medi-Cal member can access. So in an ideal workflow, right, a client would come in, they'd be screened maybe by a CHW, see if they're eligible. If the person is eligible for ECM services, which is a higher touch point, then they can do a warm handoff to like a lead care manager. But if the person isn't eligible for ECM services, like maybe they're Medicare or they have private insurance or they're not one of the priority populations, then the CHW would continue to work with them in that scenario since it's more broad and open. And it can be on the flip side too, where like if someone is being graduated from ECM, like they, are doing well and maybe don't need that high level of connection, then they can be kind of slowly handed off to like a CHW to kind of provide ongoing support, but maybe not at that intense level.
Thank you. Do you want to add anything to that, Janice?
No, same thing, like what, just to allude to like what Felipe said, our care model is similar to, again, like what he said, which is, let's say, for example, we get like some panel of patients from either one of our IPAs or our MCPs. And if our lead care management, ECM program manager do think that this person can actually graduate to the ECM program, and then they would do like a warm handoff communication to the CHW and say like, hey, this patient, it doesn't seem like is needing all this like interdisciplinary care. So I'm passing it on to you. And then vice versa. If our CHWs do determine that one of their clients, one of their community members do need more like a higher acuity level of care, more like high touch care, then we will definitely do like a warm handoff to our ECM program manager. And then again, just to prevent, from like double billing, we do have with our IPAs, our either Smollett Healthcare or LA Care, they have like predetermined, let's say, precursors. Let's say, for example, if this patient has gone to the hospital, has high rehospitalization rate, then most probably this patient is going to be under like ECM program. But if not, then probably like CHW. So there is like more like a clear cut in depending on like either if it's like a chronic illness or social determinant, like high risk for housing disparity, then we will definitely determine if this patient will go under ECM program or would go under CHW. So we have sort of like built like our own like checklist. And I do want to mention also like PAVE. I don't know if our audience here is familiar with PAVE. So it's a platform, and what I like about PAVE is not a lot to be a PAVE to be a paved CBO or a community health clinic. I think you have to go to like a tedious application. It's a little bit like rigorous like application form to be paved approved. So what I like about PAVE is we don't have to depend so much on like the like the middle person, such as like MCPs. We don't have to depend so much of like Molina Healthcare giving us patients, or LA Care giving us patients, or HealthNet giving us patients. So what we do is within our clients, within our community, we go through a list. And then if they do fall under, or if they do have, again, chronic illness, high risk for rehospitalization, or if they do have like social determinants, we are currently right now writing our own like checklist. And then if the patient falls under one of those like categories, our own primary health care provider, we will do like a case manager conversation with her, and we would say, hey, by the way, I'm using you, Felipe, as an example. This patient, Felipe has this and this chronic illness, and I think Mr. Felipe would actually very well benefit from either CHW or ECM program. And then she will sign it off, and then we will enroll that patient into our PAVE program. So the PAVE program, actually, you directly are able to bill Medi-Cal or Medicare without having so much being highly dependent on like the MCPs. So yeah, thank you.
Thank you. And for the audience, PAVE is Provider Application and Validation for Enrollment. And what it is, it's the California Department of Healthcare Services is their provider portal. So that's what Janice is referring to. And thank you for that insight, because I am sure a lot of folks was not unaware. So thank you for that. All right. So next question. So maybe for either for Ellen or Renee, can you please share more info on how CHWs are supporting the justice involved in those with behavioral health and substance use disorders?
Yeah, no, we tend to, like I said, we have our resource binder, but we also, it's scary to go and find, detox or any rehab thing, resources. So we rely on Behavioral Health Access Center. It's at 1380 Howard here in San Francisco. We go with our members. I've gone a couple times with them to sort of go through that whole process. We also have other locations like Health Right 360. I've been very fortunate enough, a member let me go with them. We checked in really early in the morning. And I let them know, I'm not gonna leave until I see you get on that bus to go to that rehab center. Like, we're gonna get you through the whole process, because he's tried a couple of times, but somewhere in between, they just sort of either give up or just like, I don't want to do this today. So I really see having someone there with you, a CHW ECM care coordinator, they follow through with it. And I've noticed a lot that people get treated differently when one of us are with them. Sometimes people walk into there looking for help and they kind of just get dismissed. But if they see you walk in with a community health worker, enhanced care management, care coordinator, they tend to give a little more respect. And we're there to advocate for them.
Yeah, and I'll add on a little bit to that, just as Renee had said, that like perseverance, we're a team, and at times there are going to be moments where it feels like we're not making progress, but it's always in those moments where it's like, let's make as many plans as we can, avenues. I actually just had a member recently. I had all the way plan A through E for this person so that we could really work on this together. I think the substance use disorder. It's one of our biggest populations of focus. And so we really are constantly looking for new resources. We are also able to refer to our medical team who help with medication-assisted treatment. So all the avenues that we have, we've tried to explore, and I'm sure that there are a lot more resources in the community as well for us to find. And in terms of like folks who have been previously incarcerated, it is a population of focus for us. I would say it's kind of one of the ones we have the least members in. But definitely, I think, you know, sometimes those populations of focus can kind of intersect a bit, and one person, you know, may have a lot of different things going on. And so kind of really focusing, we've been to court before, we've written letters in support for folks. I think as people who really see these folks day to day, we're able to, you know, really attest to their character and be that support for them when there are uncertain times.
Thank you. All right, let me get some questions from the chat. I'm curious how folks are planning for the end of Cal-AIM with your ECM programs, if you're thinking about that now. It's a big question.
Yeah, that I know it's actually yes. Definitely it's actually so sad that that it's actually that it's like ending right now. I think data shows, while the data shows that there is really like a big impact when they started like the Cal Aim. Like again, rehospital rehospitalization rate actually very decreased, and like housing disparities also decreased. So data really shows that it works. And we're hopefully, though, like our like federal funding, government actually do really buy in and listen to the Cal Aim folks and really say that like, hey, it actually really works for the community. So what we are currently thinking of planning is, once the Cal A path cited has, once it's completed, definitely just focusing again on again rated funding, philanthropic like funding. There's actually funding sources out there. There's a lot of non-for-profit organizations that are wanting to partner with non-for-profit organizations such as us here currently right now, like in the panel. So, just having like a strong like grant writer, like a grant manager, just being out there, each and every day, just looking in terms of what funding is available out there to actually sustain our ECM model would hopefully help us, sustain our current ECM program right now. Because right now, I do think that we're like in the middle of it. It's not as I would hope for it to be like peak through or robust. We're still in the middle of it. That's why it's sort of like sad that now path cited is like ending, where we're actually seeing numbers and trends and data saying that this model actually works. So for the folks out there who's like in the federal government, hopefully you guys are listening. But again, and I do suggest for everyone to look into the PAVE model, because again, cutting like the middle man, and not waiting for them to actually give us like patients, but just being more proactive. And because we already have like our panel of patients, right? That, especially if with Felipe, you guys are like what, have 12 clinics, like as you say. So just in that 12 clinics, you probably have like thousands of patients that would definitely benefit from like a CHW ECM program. And if you guys have the PAVE model, you can directly provide care and billing to your current clients right now.
Thank you, Janice. Okay, so this next question is about workforce development. So I'm curious, and it's two questions together really. So I think folks are asking how for Ellen and for Renee, how did it evolve from CHWs into lead care managers? And was that a different certification? And what was involved with that kind of, what was that pathway?
Well, I would say in our experience, my experience, the community health worker and like connection with the consortium and our own member clinics was kind of that first piece of the puzzle. That was where we were offered the year-long training at City College, which was really the foundation for our success in ECM. Native American Health Center after COVID had been dealing with a lack of staffing that really focused on social determinants. And so we were kind of filling that gap. And I think that having that education was really integral into being able to transfer it onto on-the-job experiences. And I kind of remember, I think it was almost 2 years ago now, in the summer where ECM was a new thing. Our agency was talking about it, and I kind of sat back and thought, wait, this sounds exactly what I'm doing. Like that kind of really comprehensive care. I think at Native American Health Center, we kind of met the need, and we had a lot of high needs. So kind of right off the bat, I think we were doing some of that kind of work. And so, yeah, it was kind of a lot of negotiating, and we were bearing witness to this process and seeing what it meant for us, because we wanted to make sure that we were able to follow our patients who would be eligible for this new program. So we were able to transition, and it was a departmental transition from our medical department to our behavioral health department. It's just kind of how the mechanics worked out for us. And we had still more to learn, but I would say that the community health worker relationships, patient connections were all really integral in being able to make that transition smooth. The ECM training itself, I would say, is not as comprehensive as the community health worker training that I was part of. And so I would say that that was really a key experience.
Thank you. We're almost at the end of our time, and I want to make sure we're getting some closing thoughts from you all. So maybe very quickly, if each of you can answer this question, when the goal is to build systems that sustain and grow the role of community health workers, promotores, and community health representatives in ECM care teams and programs, what matters most from your perspective? We'll start with you, Felipe.
I would say on my end, kind of in this work, we really need to support our frontline workers and really need to be intentional about the way that we support them because this work is hard, right? Sometimes we'll think that like a provider may have a mindset that, oh, you're just giving them like a handout, a referral, a little like flyer or something. And we know that it's not that it takes so much to get our communities into our clinics. And then it takes so much work after they leave our clinic to really support them and have that full picture. And the work is hard, and being able to provide daily check-ins and support after a difficult case or a difficult situation is so necessary to be really in collaboration with our staff who are holding so much of the direct work that we're doing. Yes, there's like technical things around billing and stuff that require a lot of work too, but the emotional labor, the like secondary trauma that our frontline workers face. Like it's not just this person went off to find a different job. It's like we're not doing a good job at supporting our frontline workers, and we need to do better.
I think we have time for Renee, and that's about it.
No, I would honestly just say on the top two things would be having that resource binder, I think is really key. And then just building relationships. I've gone to the hospital many times and I've gone for one patient. I've met the provider a couple times, and now I go with a different patient and I see that provider and we check in. So I think just building relationships is the biggest thing.
Thank you so much. So that is all the time we have today. I could talk to you all all day. But I just want to thank you all so much, all the panelists, our funders, the team. And if you all could just take just a couple seconds to fill out the poll, we would really greatly appreciate it. And then just as a reminder, in about 15 minutes, we inviting back our Amplifying Impact Initiative participants to an open discussion and debrief. It is optional, but we'd love it if you could join us at 11:15. So with that, thank you all so much for being here. And for the questions we didn't get answered, we'll try our best to get those answered via email. And we will be sending out the recording of this webinar in about 2 weeks. So thank you all for being here, and have a wonderful rest of your day.